Welcome, and thank you for joining us today for the meeting of the New York City Health and Hospital Capital Committee. Today's meeting is officially called to order. I would like to propose a motion to adopt the minutes of the Capital Committee meeting held on November 15, 2021. I will be polling each member individually to get his or her vote. Jose Pagan? Jose, I see your video, but maybe you have audio problems. Jose, can you hear me?
Yeah, I can now. Yeah.
Okay, good.
Sorry.
With respect to the motion to accept the meeting minutes from November 15, 2021, how do you
Yes.
vote? Thank
Yes.
you. Dr. Katz?
Yes.
Frida?
Yes.
Sally?
Yes.
The motion carries. Thank you. Next, we will have the report from the Senior Vice President, Ms. Flaherty.
Good morning, Capital Chair Piñamora and Chairman Pagan and our entire Capital Committee. I first want to thank our Directors of Engineering at our 3 sites, Lincoln, Coney Island, and Kings County, that had successful joint commissions just as recently as last week under Chris Roker's leadership at Lincoln. In all cases, our life safety areas and environment of care areas did not have any conditional findings, and that's due to the hard work of the Directors of Engineering and all of our trades. Our office is really excited to share our partnership with DCAS, and we have identified future installation of solar panels at Woodhull, Elmhurst, at Jacoby as our first 3 pilot sites. We are just now in the early stages of working with DCAS on these 3 exciting projects, and so they'll start with the planning and design process, but I did want to share that with our Capital Committee. The bond portfolio remains a critical body of work where we are working closely with our facilities. Unfortunately, the global supply chain issues are directly impacting this portfolio of work. Overall progress on the bond portfolio is progressing, with 14 projects finishing up design. To start procurement, projects are in procurement now. Based upon some of these early bid results, our completion goals will require time adjustments. We learned that a number of projects that are impacted have to do with roofing systems. There's major supply chain shortages in this area, in some cases impacting as much as 18 months for certain materials to arrive. And so we're working with our designers and our vendors on developing alternative solutions while still maintaining the quality and integrity of the roofing systems to see if there's any other options to bring those schedules back and keep it within budget. 4 projects are in construction now, and 1 project is completed, for a total of the 35 projects that remain active today. At this point, I'm happy to go through the 3 resolutions we have and to take any questions from the Capital Committee.
First, let's find out if there are any questions or comments about your report. Is that okay, Christine?
Sure.
Okay, so I will go to each member if they have any questions, comments about Christine's report. Jose?
No questions, just glad that things are moving along despite everything that is going on in the backgrounds. Thank you.
Thank you. Dr. Katz?
No questions, thank you.
Frida?
No questions, thank you.
Thank you. Sally?
No questions. Thank you.
Christine, I just have a question, is that following up on the email that Dr. Katz sent about our preparations for Omicron variant, is there anything that the Capital Group is doing, or all the investment that were made in the previous waves of COVID has been able to be useful for this new potential wave here?
Yes, so I think we're working closely with emergency management and all of our site leadership. Many of the enhancements that were made are being used as we speak, especially for critical care related areas throughout our hospitals, whether that be at Elmhurst, Bellevue, Coney Island, and across our sites. I would say that we're watching this closely and working closely with each of the site leaders as each of them have their surge plans in place, and we're reviewing them just to ensure that there's no additional, things that have to be done. We have not identified any additional work thus far, but we're meeting every day and we're looking at the data, we're looking at the census, and again, we're connecting with the CEOs directly just to ensure that they're in the shape that they need. So currently, we don't have any emergency activations that were needed yet.
Okay, thank you for the report. It is very comforting to know that the investments that were made and all the work that was done continue to be of help and support to the different units as they are responding to these new variants. So thank you so much. So I think that if there are no further questions, we can go to the resolutions.
Great. Our first resolution is a request for authorizing New York City Health and Hospitals Corporation, NYC Health and Hospitals, to execute a contract with Gemco Electrical Contractors, Inc., the contractor, for amount not to exceed $7,234,156 for construction services necessary for the main distribution frame, MDF, and data closet upgrade Phase 2 at NYC Health and Hospitals Harlem Hospital, Harlem, with a 10% project contingency of $723,416 for unexpected changes in scope, yielding a total authorized expenditure of $7,957,572. I'm joined today by Dr. Eric Way, our acting CEO at Harlem. And if we could go to the first slide, please. Eric will provide some of the background associated with the necessary needs of this project. Dr. Way?
All right, thank you, Christine. I feel like I'm still catching up for my HVAC course in Christine's School of Engineering, and now we're moving on to data centers. So the project background in layman's terms, as I understand it, is that our IT data center was housed in the Women's Pavilion, and with the demolition of the Women's Pavilion to build a new public health lab, we now need to move the data center into the second floor of the Mural Pavilion. It requires electric, HVAC work to ensure that there's sufficient power and cooling for that equipment, the IT equipment in there. So that's phase one. The second is installing a second redundant system in the MLK building. They'll provide power, normal emergency from the MLK building power system, interconnecting this UPS-B power source with the Mural Pavilion, MDF. And this phase will distribute UPS power from the MP, MDF, to the MLK and Ron Brown Pavilion IT closets. This also includes upgrading the AC systems for MLK and Ron Brown to be able to ensure that we can cool that IT closet. So that's as I understand the project, and I'll turn it over to Christine.
Thank you, Dr. Way. You did an excellent job describing the scope of this project, and I think you were an engineer in training in your prior days somehow. So wanted to share with you the sourcing of this contract. This was a public bid out to the whole market. Gemco Electrical Contractors, Inc. was the lowest of 3 bidders, and they had an MWBE subcontractor utilization plan of 36.44%, which included largely services and some supplies. The subcontractors are listed here. The contract bid amount is $7,234,156, and the MWBE amount is noted in the slides over $2.6 million. Gemco is working at a number of projects across our system. They're the Jax Electrical Contractor and the previous Jax Electrical Contractor. Their evaluations were rated in the 93 to 93% respectively for both of those service agreements. And they also have ratings in the MOC system in Passport, 3 excellent and 4 good. The project completion for this project is anticipated to be in 2023. And if we go to the next slide, this shows you a breakdown of the project budget between the bid and the construction contingency that we would have in place with our capital proceed. And the final slide is the resolution itself. that I read early on in the presentation prior to presentation. We're happy to take any specific questions from members of the Capital Committee.
Thank you, Christine. Let me go in order of the members. Jose,
No questions, thank you.
Dr. Katz,
No questions, thank you.
Frida,
No questions. Thank you.
Sally, thank you.
I
Sally,
just had two questions. What amount of space did the data center occupy in the women's pavilion, and how much space will it occupy now?
That is not a stat I have in front of me. So, and this is this scope. So phase 1 that's listed on slide 2,
I see, yeah.
that's complete.
Okay.
I feel like it was around 5,000 square feet, but we can get you the exact square footage. And then this second phase really is about the new space, but also a ton of work inside the existing data
Right.
closet. So a lot of this is pipes and distribution systems and cooling,
Mhm.
which we frequently are doing as kind of our phase 2 work
Mhm.
after Epic implementation, as well as creating that redundancy. We can follow up with you about square footages.
And the redundancy we're working now with closets, and I'm used to like property, so it gets me a little confused. The redundant capability, will that be used by others, or is that a dedicated?
That's dedicated to Harlem Hospital.
It is dedicated to Harlem, that's what I meant. but
Correct.
It's not dedicated only to the data center. Or is it? It is.
Yes, it's
Okay,
for the data itself, to keep
Okay.
everything running.
thank you.
Thank you.
thank you, Christine. I just have a comment for maybe you, and I don't know if Eric can elaborate on how this connects with the plan that the IT group has in terms of the data centers relocation. I know that in some facilities, they are trying to migrate out of having data centers in the facility and have a remote where it's going to be secure, backup with triple or quadruple redundancy and security. How does this play with that large initiative that Kim Mendes is leading?
I'm going to have Menji help me answer this question, since he was involved in the first phase of this work, as well as supporting the facility on the second phase.
So at the acutes, there's some applications that are still required to be locally based at the site. So for that reason, I don't think this is part of their plan to migrate any of these data centers off to a remote site as of yet. There's still a requirement to keep some of the applications used at the facilities local to the facility.
Okay, and so, but whatever upgrade is done here is coordinated in terms of the technology, the hardware, the software that is going to use, that is all interconnected. Because from what I understand, this migration is changing some vendors, and there is some upgrade on the kind of the whole infrastructure for data center. So I just wanted to understand how is all this coordinated and they are all kind of in a way integrated.
So typically IT provides us with their design spec or their design standards for data centers in terms of cooling and electrical, and we work with our vendors to design to those specs. So we work very closely with IT to ensure that we're meeting their requirements and their standards when we do this type of work.
So what we have here is only the infrastructure work in terms of
Correct.
the space, the electricity requirement, HVAC requirement, but the whole hardware and software is separate. And so the
Correct.
budget that you present here, does it include the hardware and software, or is only the physical infrastructure investment?
This is only the infrastructure investment
So
related to cooling and electrical.
So are we?
Sorry.
Yeah, now I understand. So in that case, are we expecting to see a new kind of resolution or a proposal to fund this, or do you know if the money for that, the hardware, software, will be is already accounted for on the overall plan that Kim Mendes have for these data centers?
So my understanding is that when it comes to the hardware and the software, that's included in their annual refresh budget that IT has. But we'll have to confirm that with Kim. I don't want to speak for Kim. I know they have an annual refresh, and I know they include data center, both software and hardware, in that refresh. If this is specific to Harlem, I can't confirm that, but I'd have to
Okay.
speak to Kim or Jeff.
I think it would be good to know that before the meeting, before the board meeting, because this is more than a refresh. This is actually an opportunity to rethink what the hardware and software will be, and make sure there is a line and allows for whatever the regulations permit to have security, duplication, data retention, data warehousing. So it would be good to have that, and maybe have Kim ready to answer any question that may come related to that part, because I think has to be kind of very tightly integrated between the IT and the capital group.
Yeah, we're happy to do that. All of these types of projects are very carefully worked with the EITS lead at the site that works very closely and directly for Kim's office. So all of the objectives here, the needs here are absolutely carefully coordinated with their office. We will add some of those features for the full board meeting, and I'll work with Kim and ensuring their participation during full board.
Thank you, Christine. And if there is not too much to ask, perhaps have a slide on how this fits on the overall strategy, because the overall strategy of the data center, it has been clearly communicated to the board. We have seen kind of the transition that are already happening. So it would be good how this fits in the overall universe, and ensure that everything is all interconnected and working together.
Thank you for that feedback.
Thank you. Any other questions or comments? Okay, thank you, Christine. So now I think,
Thank you.
do we have to vote? I believe so. So let me ask each one of the members for their vote. Jose?
Yes.
Dr. Katz?
Yes.
Frida?
Yes.
Sally?
Yes.
Feniowski also vote yes. Thank you. So now we have the second motion.
Our next resolution is a request authorizing New York City Health and Hospitals Corporation, the system, to execute a revocable 5-year license agreement with River Renal Services, Inc., the licensee, for its continued use and occupancy of 7,817 square feet of space to operate a renal dialysis center at NYC Health and Hospitals Bellevue, the facility at an occupancy fee rate of $68.50 per square foot, or $539,163.50 per year, to be escalated by 2.75% per year, for a total of $2,848,221.26 over the 5-year term. And now I'll hand it to my colleague, Mr. Bill Hicks, who I believe is on the line. Bill?
Good morning, everyone, and thank you so much for the opportunity to present this agreement today. So for clarity, the resolution really has 2 components here that we're looking at. One is the space licensing agreement for a separate Article 28 licensed outpatient chronic hemodialysis center that has been at Bellevue for, this is our second cycle re-up. And the second, it's a service agreement to provide acute inpatient hemodialysis on a 6-bedded unit that we have adjacent to that unit as part of River Renal's chronic outpatient unit. So I'd just like to add that River Renal, has had an extraordinary partnership with us, and certainly throughout COVID. Prior to COVID, we were seeing about 8 patients per day. Now about 18 patients per day at bedside here. So on the outpatient side too, we also have seen an extraordinarily growth in the number of patients that they're able to serve. If we can go to the first slide here, you can see, I'm sorry, back one, please. Back one slide, thank you, Menji. So River Renal has, as I mentioned, has their own Article 28 certification here and is in good standing. We have monthly quality meetings with them. So it's integrated into our performance improvement quality process here. River Renal, as I mentioned, operates 18 outpatient stations on the 5th floor. You can see an image of that space there. There's quite nice environment for our patients. We have TVs and things like that for their comfort. So River Renal also provides the training, medical support, management equipment, supplies for our outpatient hemoperitoneal dialysis patients and home hemodialysis patients. So next slide, please. So as I mentioned, we have 6 stations that we treat our inpatient population. And again, it's co-located on the 5th floor. River Renal provides the nurses for our inpatient dialysis treatments. And here's where that partnership really, showed itself, as I mentioned, throughout COVID. And as you can imagine, the number of patients that we were seeing that required to save service just went exponentially up. And they were there with us there every step of the way, being able to expand their services, again, to meet the needs here at Bellevue. So we were quite appreciative of that. And as a last item here, on their responsibilities, River Renal also provides the water management system that's there. It's a very, it's called a reverse osmosis system. And so they actually do all of the quality control and do all of the daily chlorine and chloramine testing that's required to make sure that we have good quality water service for our patients. Next slide. And so this agreement began in 2011, and I actually had the opportunity to present the first renewal to the board in 2016. River Renal provides approximately 197 outpatient treatments weekly with their current patient census of 72 at this point. Bellevue bills third-party payers for our inpatient treatments provided by River Renal, and River Renal bills third-party payers for its outpatient treatments. And we have this a very good relationship with them. We see very few patients that are not covered, and that River Renal does not accommodate those patients. Every single one of our patients that we need to get into the service, we're able and have access to it. So I just want to use a quick example of, we had a patient, as you know, we have a very big behavioral health component here at Bellevue. And we actually worked out an agreement because we did have a patient that needed to have some one-to-one monitoring while they were in the suite. And so it's just another example of the way that we are able to work together as a facility and as a service here. And as the last point here, I want to say that Bellevue pays the established Medicaid rate for treatments provided to any patient who could not be enrolled in insurance. There's very few of these patients. By my research, right this past year, we paid for less than 6 patients. So we have an incredibly strong, as I said, relationship with them in terms of the finances and in terms of their access and outpatient access to their services. And then lastly here, I'm going to tip it over. Yes, Christine, I'm tipping it over to you. Thank you.
Thanks, Bill. Thank you, Bill. So just quickly, as previously presented to the Capital Committee and the board in our Elmhurst Dialysis recent resolution, we do have outpatient dialysis that H&H provides at Metropolitan Harlem, Kings, Lincoln, NCB, and Jacoby. Newtown provides that outpatient dialysis treatment at Elmhurst. And we also have an agreement with Dialyze Direct for inpatient dialysis at Kohler and McKinney. So it does vary by site, as discussed previously. For the terms of this license agreement, River Renal will continue to occupy that 7,817 square feet on the 5th floor of Bellevue's H-bed tower at the rate of $68.50 per square foot, for the total of $539,163.50 per year. This is set at fair market value for the space. The Savit assessment is attached in the backup for this resolution. And the payable rate for Riverina with this expiring license rate, this is about a 4% increase from the current rent that's being paid right now. The occupancy fee, should this be approved, would be escalated at the 2.75% per year over that 5-year term we're requesting, showing the total of the occupancy at $2,848,221.26. Bellevue provides the hot and cold water, electricity, heating, air conditioning, security, and maintenance to the licensed space within the H Tower. And Riverina will provide the housekeeping and red bag waste removal as currently operationalized. And finally, the last slide is the resolution, which I already read into the beginning prior to presentation. We're happy to take any questions. Thank you so much.
Thank you, Christine. Thank you, Bill, for the presentation. Let me go through each one of the members for their comments. Jose, any comments, questions?
No questions, thank you.
Dr. Katz,
No questions, thank you.
Rita,
No questions. Thank you.
Sally?
Just 2 questions. One, this is an outstanding example of using an external contractor to provide such a critical service. And I imagine you weighed the pros and cons of doing it yourself and decided that this was a more cost-effective way of doing it. Are the 6 beds that are inpatient beds, are they ever used as backup to your outpatient beds, or those are really reserved for inpatient use?
Those are reserved for our inpatient needs, yes.
Okay, that's it. Thank you.
Thank you.
Okay, I think you said 2 questions. Sally, did I miss the second one?
No, I probably missed the second one. It's okay, Fanny.
I just want to make sure that I keep track, okay? But you don't have any other questions. I just want to make
No,
sure.
I don't.
Okay,
No.
thank you. Bill, I just have a question. In terms of, you say the growth of the patients seeking service, that when I believe, I remember 8 to 18, is that correct? Is that the number that you said pre-COVID and now after, during COVID? Did I get the number right?
Yeah, so we went from 8 patients per day to 18, and at Bedside, when we're talking about our inpatients, we went from 2 to 4 a day to about 6 to 8 per day, which we're running as an average now. So the program has grown quite a bit and grown with us.
And so, what will be the new capacity, or what is the maximum capacity? I think that's the question. And the operating hours. I don't remember hearing those things. If you can share that. Is there something that we need to start thinking about increasing capacity? Again, I'm not so sure. You know more about the trend that is happening and how is that going to continue in the future?
Yeah, well, I mean, it could be a possibility. The last 10 months average was 278 treatments per month. And now in November, we did 319. We would expect that spike during this period of time. We're seeing a little bit of a bump in COVID. But they have grown with us and demonstrated that they're able to do that. Right now, we don't feel the terrible pressures to increase that, but we always have a plan in our pocket.
And the space that you have, again, you're saying that you're not planning right now to increase, but the space that you have, or we are approving here, you think will accommodate for any potential growth if it is needed, or we are almost at capacity at this point?
I would say that we're almost at capacity when you look at it. I mean, to be comfortable and to give our patients a good experience. I think it's a well-run place. It's very aesthetically pleasing. We want that to continue. That we have, by the way, I looked at our accounts receivables on this. We have a lot of commercial payers that are coming to Bellevue, so that's good. We want to grow that, and we're keeping our eye on that. So that's one way we can do that. Give them a good experience.
Thank you. And what are the operating hours? I don't know. You may have mentioned it, but I don't recall.
I don't know. By the way, on the sideline, off camera here is Marcia Peters, my COO. I don't know if she knows the hours of operation for it.
The hours of operation, they start as early as 6 a.m. and they go from the chronic to about 8 p.m. With the internal service, our chronic service, of course, it's 24 hours. If they can't accommodate them on the 6th floor, we have the bedside service. So that side of it, the chronic is 24 hours.
Thank you. And do they operate Saturdays and Sundays and holidays, or it's only working days?
I know they open on Saturdays, I'm unsure of Sundays. But the services, they accommodate the patients. So if the patients require a 3-day treatment, they ensure that they have that 3 days. So they work their schedule around so the patients always get the services that they need.
Okay. Thank you for those clarifications. I don't have any other question. Again, great service, and like you're saying, this provider has been really good and ensuring that the patients feel kind of welcome, comfortable, and treated with a lot of dignity and support. So thank you. Is there any other questions from any of the members? No,
Just a quick thought. I just had a quick thought. We recently approved dialysis, I don't recall where, but they had 3 days and 5 days, depending on I think it was like the power of the machinery that was used. Are yours like able to work, do all of them work and result in a 3-day treatment plan? Do you know, Bill? I was just.
Not exactly positive.
Okay.
I think I know, Sally. Sally, I think you're thinking of the home den dialysis. The presentation that we received about the dialysis that we're using at a skilled nursing facility, which is it's a slower dialysis, generally not recommended for acutely ill patients, but excellent for people with chronic renal failure who need dialysis.
Okay, thank you.
I just want to add a note associated with Marcia's comment about bedside dialysis. Some of our emergency work we supported Belmont had to do with additional bedside capacity for the machines to hook up, especially in our flex ICU areas, to allow that service to come in as required. And so just supporting the capacity question, Paniowski.
Well, thank you. That's very, very good. Thank you. I appreciate it. Any other questions before we take the vote?
Last one, I swear.
Sally, I knew you had 2. Now it's 3. That's good. Go for it.
Okay, I'm going to get punished next time.
No.
So just adding up the hospitals with dialysis, there are 1, 2, 3, 4, 5, 6, 7 hospitals, and then Kohler and McKinney. But do you know if there are plans to do the other 4, or is the need there not as it tends?
So I think we can update this sheet because we
Yeah.
do provide, there are, well, I don't want to speak for our CEOs, but I know some of them are working on plans associated with expanding our outpatient dialysis capacity. And so I don't want to jump in front of them announcing their plans, but it's definitely being looked at, the chronic conditions of our patients and the needs, and ensuring that we are providing outpatient dialysis where all the needs have been identified is something that is in the works from a planning perspective.
Right. Just to say a little bit more about outpatient dialysis, to put it in context, historically, public hospital systems in recent years stopped doing dialysis when dialysis became an automatic eligibility for Medicaid and Medicare. So there were no longer any purely uninsured patients. And the combination of that plus the ability of many of these large national groups to do dialysis less expensively because they get cheaper supplies than we'd ever be able to get. So that sort of made the movement from the traditional role of public hospitals, which would have once always provided dialysis to outpatients, to more and more, having it be done in the community. I think what's developing now is this sort of hybrid model where we recognize, especially for our most vulnerable patients, it's better if the dialysis can be tied to the hospital in some way, since they're used to going to the hospital. And so in these hybrid models, we're essentially using our space, but still taking advantage of the buying power that these large agencies have, so that we can have dialysis at our sites without having it be unaffordable, or that we're just not, again, there are other advantages that sometimes come with being a large, dialysis firm. Dialysis is just, one of the things that we do. It isn't necessarily, our best, personally delivered service. So I think the other hospitals are looking at it to the extent that they feel that their patients don't have adequate access in the community. If they're outpatients and they have adequate access, then there's not a clear pressing need.
Right. Okay, thank you, Mitch.
Mitch, I really appreciate your comments, because I think what you're trying to get is the best of both worlds to provide the patients with the care that they need. If they are already coming to the hospital, they have access there at the most affordable as well as the best experience possible. I think that sounds like the best world, the best of the two worlds. Thank you for
Thank you,
sharing.
Fedi.
Any other comments, questions before we take the vote? Okay, so I will call each member now. Jose, how do you vote?
Yes.
Dr. Katz,
Yes.
Frida,
Yes.
Sally,
Yes.
Feniowski also vote yes. Thank you. The motion carries. Thank you, Bill, and for sharing, and thank you for having, even though it was out of the picture, she was there to fill in. So thank you for joining us and sharing your knowledge. We really appreciate it. And so now we have, Christine, I think your third resolution.
Yes, our next resolution will be presented by my colleague, Dr. Long, authorizing New York City Health and Hospitals Corporation, the system, to execute agreements for license renewals for the use of space at the 3 mass COVID-19 vaccination testing sites, the 12 pop-up COVID-19 testing sites, and the 1 storage site listed in Annex A attached to this resolution, together the sites. And through an agreement with NYCHA, various locations on NYCHA property for no longer than 1 year for a cumulative amount of not to exceed 4.4 million, plus an 11% contingency of 500,000 to cover site repairs and utility overages for a total of $4,900,000. And I'll hand it to you, Dr. Long.
Great. Well, hello, everybody. Hello, Feni. Thank you for having us today. So if we want to go to our slides here, we can start. Oh, there we go. Slide 1. So the backdrop to this is, unfortunately, in New York State today, we are seeing cases go up. We are also seeing the beginning of the emergence of the Omicron variant emerging through spreading in our communities. Now, the scary part about the new variant, about cases going up, is that we've seen this before, and we know if cases are going up now, that we know that there is spread going on in New York City today. But the good news about this is that we have the strongest testing infrastructure in the whole country. We have 89% of all adults in New York City who received at least 1 dose of the vaccine. And in the last week or two, we've been doubling the number of boosters we've been giving out at our H&H sites. So New Yorkers know what to do. We have a winning formula for controlling this thing. And what I want to tell you about today is what we need to do to hold the line, and what's worked all the way through COVID, that we needed just a little bit more to get us through this next period as we get enough New Yorkers vaccinated, and as we can start to see, hopefully, the beginning of the light at the end of the tunnel. So first part of this resolution, it's a multi-part resolution, is our vaccine sites. So by way of background, early on when the vaccine first came out, we wanted to do everything that we could to bring equity and access to New York City by opening 3 large mass 24/7 vaccination sites, one not far from where I practice in the Bronx, one in Brooklyn, and one in Queens. We've actually kept them going 24/7 for the last almost a year now. This has enabled, again, people that work during the day or work at night rather to get vaccinated overnight if that works for their schedules, to remove all access barriers to help New Yorkers to get vaccinated. Here we list the 3 sites, so to go into a little bit more detail. The sites are Brooklyn Army Terminal, so that's on the left-hand column here. That first started, we opened that site on January 10th, 2021. Second is Bathgate, that's in the Bronx. We opened that site also on January 10th, 2021. And then City Field, which has done the most vaccines of any site in New York City, we opened on February 10th, 2021. Currently, Brooklyn Army Terminal and Bathgate use Moderna. City Field offers the Pfizer vaccine, including to our new 5 to 11-year-old population. We're starting to see them come out, which is very encouraging. And for each of these sites, we don't pay an occupancy fee, but we do pay for gas and electricity. And at City Field, we reimburse the Mets for some labor cost incurred to accommodate the use. In totality, these sites have delivered more than 450,000 vaccine doses just at these 3 sites. They operate 24/7, like I said, and we want to keep them operating as we get as many New Yorkers vaccinated as possible. Next slide, please. So changing gears, that's what we've done on the vaccine front. That's what we believe is important to keep our city safe. And the success we've had, again, doing more than 450,000 vaccines to date at those 3 sites alone. Testing is now more important than ever as well, especially as we're seeing, again, the Omicron variant emerge through community spread in New York City. These are our 12 community-based testing sites that we've had. These are, we refer to them as our brick and mortar sites. And in a minute in the presentation, I'm going to give you the full picture of how these complement and are related to our mobile testing effort to bring equity of testing into every community in New York City. So for these sites here, all sites offer PCR testing. 9 also offer rapid molecular testing. These 12 sites have done over 580,000 tests of unique patients as of November 17th of this year. We do not pay occupancy fees, but we do pay electricity at 1 site. And we want to continue operating these sites below here. So I'm just going to read them off to give a flavor of where they are. So we have the site at Bensonhurst, 14th Avenue, Midwood, Bay Ridge, 5th Avenue, Starrett City, Fort Hamilton, Times Square, Sorrentino Rec Center. We've had long-standing sites at the airports as well, JFK and LaGuardia, and we now have mobile units. Greenbelt Recreation Center, St. George Ferry Terminal, Staten Island, and 57 Cleveland Place, also in Staten Island. Okay, next slide, please. So in terms of, those are our brick and mortar vaccine sites and brick and mortar testing sites. Another important piece that relates to our overall licensure agreements is that we've really out of the gates done everything we can to support our communities living in our NYCHA developments. So from the very beginning, we offered mobile testing to bring the tests, the COVID tests, literally not just to your doorstep, but through your doorstep at our NYCHA developments to make sure that we are giving everybody equal opportunity and access to get testing across New York City. We also, on the vaccine front, have been at multiple NYCHA developments. We've provided clinics to over 60 developments to date. That's for the vaccine. We have plans now starting December 14th to go to at least 10 more developments with high concentrations of children, given that we can now do the vaccine for 5 to 11-year-olds. So in terms of being able to continue testing and vaccination in our NYCHA developments, we here list out that we need to have a master agreement to apply to NYCHA developments across the 5 boroughs. There's no license fee or pass-through costs associated with our use of the NYCHA space, and the proposed resolution, this piece of it, would extend H&H's master agreement with NYCHA through 2022 to enable us to continue to do the good work that we've done to date, working directly with NYCHA, again, bringing testing and vaccine, not just to your doorstep, but through your doorstep, into your home. Okay. The next slide here, I wanted just to get to round off the picture a little bit. So I've shared with you our brick and mortar sites for testing and vaccine. I've shared with you our relationship with NYCHA and how we've made that a focus to bring testing and vaccine equity to New York City. And I just wanted to complement the rest of the picture here to give you an overall sense of our strategy. So in addition to the pop-up sites that we've talked about, or the brick and mortar sites that we've talked about today, we have an impressive mobile fleet. We've actually recently doubled the size of our mobile testing fleet. We have a fleet of 70 mobile testing and vaccination units. And what that enables us to do is we work with our community-based partners, our community-based organizations. We have a very active Test and Trace Core Community Advisory Board. They'll actually be meeting this evening. I'll be joining for that. And they tell us, where they believe we'd be able to have the highest impact in their communities. And that's been our mantra throughout in terms of our mobile units. We work with our communities, work with community leaders, community-based organizations, and we bring mobile units to where they're needed the most. And who would know best where they're needed the most? It is our communities themselves. So that's really been a cornerstone of our efforts. A couple of other notes in terms of the overall strategy here is that we've heard from some communities that they wanted to have other options in addition to the anterior nares test, the one you put up your nose and swirl it around. So we've been able to build out saliva-based testing through an independent vendor, which I'll be talking actually about a little more in the finance committee meeting later. But also our mobile units do saliva testing as well now. So there's really no wrong way to get tested. We want to make it accessible however you're most comfortable getting tested. We want to offer that to you. And then finally, in terms of our overall strategy is one population of people in New York City that we've had a particular focus on because they can oftentimes be some of the hardest to reach people are homeless people that are living on the street, especially homeless people living on the street and actively using drugs. So we created 6 street health outreach and wellness units or SHOW units to directly address, to give us the ability to meet people literally where they are. So we set up those mobile units, we have roving teams, and that's enabled us to do an unprecedented level of testing and vaccinations to among New Yorkers that otherwise are some of the hardest people to reach across New York City. So just to give you a sense of this, of the breakdown here in terms of our mobile versus brick and mortar sites, in a given week in November of 2021, we conducted 45,000 tests in that 1 week. 18,000 were at our brick and mortar sites and 27,000 were between our mobile units, our SHOW, street health outreach and wellness units, and our vended model, including saliva testing. So as you can see here, the balance actually we've shifted over time towards being part of our mobile units where we can really move things around. And I'm really proud to say that most of our testing now done by T2 is done driven and led by our communities, and it can be at a different place every day, different place every week. Our communities tell us that's what we're doing. That's how we're doing most of our testing today, which I think brings again a very high level, an unprecedented level of equity to New York City. Next slide, please. So a related note to all of this, but because it actually happens to be at one of the same sites, is we, separate from our vaccination site at Brooklyn Army Terminal, we have a rather large storage facility there, 56,000 square feet. We use this for storing PPE, decommissioned equipment, other T2 test and trace core supplies. And we've not been able to identify a similar opportunity for storage across New York City. So we'd like to continue to use the current facility that we're using, which happens to be at the same Brooklyn Army Terminal location where we also have our vaccination site in Brooklyn. So next slide, please. And we're at the point of the capital committee approval request. I'll turn back to Christine. Happy to answer any questions. Thank you.
Sorry, I needed to unmute. Thank you. We really appreciate it. Let's go by each one of the members for any questions or comments. Jose?
No questions. Thank you.
Dr. Katz?
No, I mean, I hope the board feels proud that we have the best, testing and tracing operation anywhere in the US, and that it was, a little contentious. People will remember at the beginning because it was chosen to be done at health and hospitals, but it's been a huge success. And I think everybody agrees that in order for it to succeed, it needed the engine of health and hospitals. And I'm just very proud of the job that Ted and his team have done and how many lives they've saved by testing people promptly and tracing infections and isolating people, right? This is as important or more important in saving lives as ventilators and medical care because this actually prevents infections. So thank you all.
Thanks, Mish.
Thank you, Dr. Katz. Now, Frida?
Thank you. And Mitch, you spoke for me, and so you can be assured that I think the board recognizes just how tremendous and this work has been, and Ted, the access and equity in terms of how we're running the program is just really, it's clearly at the forefront, and we're saving lives and keeping the city open and safe. It's really, we're very proud. And I know there's several more coming through Finance Committee, which will talk about this more. So I just had a couple of questions.
Yeah.
One more is a little bit of curiosity in terms of Omicron and sort of the, in our testing sites, do we do the genetic testing? Is that sort of how are we tracing the spread of the variant?
Yeah, good question. So the way it works is a PCR test that has adequate material that's extracted as part of the test. If it goes to one of our labs, like the pandemic response lab, there's a random sample, which on the order of New York City, we're doing about 15% of all cases. We're sequencing them, we're genotyping them. So basically, the sample goes to the lab. There's a sample, a randomized sample of that taken. So if you get tested at one of our sites, you could have your sample be genotyped for Omicron.
I see.
But
Okay.
it's not a clinical test, Frida, at this moment, because it doesn't have any clinical application at this moment, whether you're infected with alpha, beta, right, delta, Omicron. It has tremendous significance for the community, right? So knowing that 99% of the current infections in New York City is Delta is incredibly important.
Right.
Identifying when new variants come is incredibly important. For the individual who's infected, no, because the whole spectrum of disease from 0 symptoms to really severe symptoms exists for all of the variants so far.
Right.
In fact, I mean, one of the interesting things is while Delta is way more contagious, the final view is, but it's no more deadly. It's about the same severity as the original. And, I don't know that we're going to be so lucky, but because I always like to hope, today's New York Times review of Omicron was saying that some scientists are hopeful that Omicron is actually a little less lethal. And that would have tremendous significance because remember that the virus that caused the 1918 pandemic in the US is still circulating. That virus never went away, but somehow it evolved over time to no longer be such a threat to humans. And so many of us, what we're hoping is that while COVID is not going to go away, it would evolve in such a way so that it would be less lethal. Right. And in some ways, a very contagious but not lethal virus is the best thing. Because if it's very contagious but doesn't make anybody very sick, then everybody gets immunity without any harm, right? So what you want is viruses to evolve in ways that make them less lethal. But anyway, this has come up because there was some initial worry, this patient wants to know if they have Omicron or not, right? And that really isn't, it's only relevant from a population basis.
Right. So it helps us to determine what's happening with the virus and how it's mutating and what the effects on public health will be.
But we wouldn't call Frida Wang and tell her your test was positive, and by the way, it was Omicron,
right,
or Delta, or
Beta.
Beta.
It doesn't change what the protocol is for
exactly.
care.
It doesn't change it in any way.
Yep. Okay. Thank you. Sorry.
Freda, I just want to ask a question, a follow-up to yours, and then I give the floor. Is that okay? Mitch, but we do not give that information to the patients, which variants they are. Yeah, that's correct. And there is no plans to do that.
There's no plans because there's no clinical significance to it.
Okay. And if a patient asks, are we going to tell them or we are not going to tell?
I don't think we even trace back to the clinical record. I don't think there's a way of, the specimens are done in bulk.
Right.
Okay, that's a good answer. We don't have a way to
have any.
So you can ask, but we don't have it.
Right. Exactly.
Sorry, Frida. Sorry to interrupt.
Okay.
Yes.
No problem. So the other are just a few on the resolution in terms of the cost.
Yeah.
The 4.4 million. I think the vac sites get to close to that, but the balance is just for the electricity at one of the testing sites? Am I looking at that?
Yeah,
correctly?
no,
There's
it's
no
a-
other cost, right, related.
Actually, I'm going to tap in my team here.
Okay.
They're saying you're correct.
Okay, terrific. And then in terms of the private sector test sites, since they're not really charging any fees, I guess that's sort of donated to us, which is great. Do we know, in
Yeah.
terms of availability, we have any agreements as to, ensuring that we have them available for as long as we need? Or?
No, it's a great question. We're working on that. So at Brooklyn Army Terminal and Bath Gates, we want to continue those sites, those being a little bit different from Citi Field, of course, and to the foreseeable future until we vaccinate enough New Yorkers. At Citi Field, we're engaging with them in regular conversation to make sure that we're still, an acceptable guest in their space. But they've been great at supporting us the whole way through. We've been there almost a year now. And I think that they're proud of the good work that we've done together to support Queens.
Great. And similarly for the testing sites, there are a couple of private ones, which I've been a user of several times, and it's been terrific.
Yeah.
Same with them, their kind of availability is.
Largely correct, although the little bit of the nuance there, which you're alluding to, is that site by site, some sites have different needs. So in the past, there have been some sites that have asked us to leave because they may have had like a paying tenant or something like that, of which we are a little bit different, of course. So anytime that's happened in the past, or like to construct a school was another example, we place a mobile unit or mobile units there to make sure the community never goes without. So these sites here, they're in the future, we're going to just stay in good communication with the landlords at all of them and be there as long as we need to support the communities. But if there ever does come a reason where the site really needs the space back and for compelling need, we would look to place a mobile unit there so that from our standpoint, the community is never without testing.
Right, great. And on that point, I saw that the airport sites were on there. I thought we had heard the stationary sites were going to be closed and we're going to go to mobile testing. Are these different or?
No, it's a good example. That's the plan now. So, as we speak right now, we're putting mobile units there. We're working with the Port Authority and with, at JFK, it's JetBlue's space, and they've been, again, great the whole way through for over a year now in supporting, testing for people coming through JFK Airport. So from our standpoint, we always want to keep testing sites where they are as long as we can. But if there is a compelling need, our commitment is to look to then place a mobile unit there. So from our standpoint, there's always testing available.
Okay, so from our approval, it's sort of, this is the current list, that things might be fluid in terms of availability and need.
For all of those reasons you just said, that's right. Yep,
Okay.
Exactly.
Terrific, thank you very much. That's it.
Thanks.
Thank you, Frida. I just want to have a process check. We are a little bit after our due time. So Sally, please ask your questions if you have any.
I'll do it quickly.
Yeah.
I just wanted to focus on Citi Field for a moment.
Yeah.
Because it is expensive, although I know it provides great service.
Yeah.
So I was wondering whether, I think you said about 6,000 people or so were tested in November at Citi Field. For some reason, that's a number.
So it's Citi Field, the most important statistic, which I'm smiling under my mask. I'm so
Yeah.
proud of it. We've done more vaccinations at Citi Field
Right.
than any site across all of New York City. The
Right.
most in New York City.
And has the level of vaccination abated over time? That's what I'm trying to get a sense of.
It ebbs and flows.
Uh-huh.
Fortunately, now we're seeing a bit of an increase with 5 to 11-year-olds now being eligible, with people now coming out more than they were in previous weeks for the booster. So both of those things are encouraging. And both of those things, to me, Sally, make me think we really need to keep this site going to support Queens.
Yeah, no, I was just wondering whether it was possible to ramp up as needed, or is that
Yeah.
a risky proposition? Do you feel like you prefer to have it cement the agreement for a year rather than just ramp up and make an agreement when you need it?
We've actually been doing kind of the latter. So Citi Field, we grouped them all together here with sort of the 1-year horizon, but some sites like Citi Field are very likely going to want their space back before that 1-year period.
Right.
That's what Frida was saying. So, at Citi Field, from our standpoint, they've been gracious hosts, letting us do more vaccines than any other place in New York City. And we're going to work with them to see what needs they have. But we'd like to be there as long as we can to support Queens, especially now that 5 to 11-year-olds are eligible, and especially now that people are coming out for their boosters, which I couldn't support more.
Number two, I have to point this out, Fanny. There's no pop-up in the Bronx. Is it that those needs are being met through through vans, and so you don't really need a pop-up site there?
We have, we have 5 brick and mortar health and hospital sites there. So Jacoby, North Central Bronx, Lincoln, Morrisania, and Belvis now.
Right.
We know Belvis. We also have our mobile units that we're able to move around the Bronx. So that's worked well for us. And I think the brick and mortar sites here, the reason I had a whole slide on the mobile work that we do was to make the point that most of the testing we do, is done by our mobile units, because we believe that's the right way to bring testing to every community in New York City, driven by our communities themselves. So the brick and mortar sites are an important sort of base, if you will, but in a place like the Bronx, we also would add on our health and hospital sites to that base, and our mobile units are really the mainstay of how we want to bring equity to the Bronx.
And we're doing booster shots wherever we were doing vaccines. We're now also doing boosters.
Of course.
Okay, thank you.
Thank you, Sally. And again, I just want to commend you for the great work that you're doing and how well prepared you have the whole system and the infrastructure. So I just want to commend you and your team for such a great job that is helping all New Yorkers. So thank you so much.
Thank you.
So now let me take the vote. Jose?
Yes.
Dr. Katz?
Yes.
Frida?
Yes.
Sally?
Yes,
The motion is carried. Christine, I believe there is no other resolution. Is that correct?
That's correct. We're complete.
Okay, any old business that we need to address? Any new business that we need to address? There being no further discussion, meeting adjourned. Thank you. And now
Thank you so much.
we're going to the finance committee.
Thank you.
See. Bye-bye.
Yeah.
Ted, I just have a quick question for you. Do you have by any chance like heat maps of the locations, like which one are seeing the most patient?